Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important form of cardiomyopathy, that is the hypertrophic cardiomyopathy. So, hypertrophic cardiomyopathy, let me tell you, it is the disorder which is characterized by the increase in thickness of the myocardium. That is the reason why it is called the hypertrophic cardiomyopathy. And that increase in thickness of the myocardium, if it is exactly at the left ventricular outflow tract, then it is called hypertrophic obstructive cardiomyopathy. Right? So, hypertrophic obstructive cardiomyopathy. So, when do we use this term? We use this particular term when the hypertrophy is exactly at the left ventricular outflow tract. Now, followed by that, what exactly is the definition? See, the definition has evolved over time. While it traditionally has been defined by left ventricular outflow tract obstruction due to septal hypertrophy. So, earlier, what was the definition of the hypertrophic cardiomyopathy? It was defined as the left ventricular outflow obstruction it is defined as left ventricular outflow obstruction due to septal hypertrophy. So, this was the earlier definition of the hypertrophic cardiomyopathy. But now it is considered as like increase in thickness of left ventricle more than 1.5 centimeter at any part of your left ventricle. Okay. So, what is the present definition of the hypertrophic cardiomyopathy? The present definition is increase in thickness of left ventricle by more than 1.5 centimeters, right, by more than 1.5 centimeters at any part of the left ventricle. Okay, so that is what is the present definition of the hypertrophic cardiomyopathy. Now, accordingly, if you see, right, according to the present definition, yes, so this was according to the earlier definition, that is increase in the septum exactly at the outflow tract, that is called hypertrophic obstructive cardiomyopathy. But in the recent definitions, the increase in thickness need not be only in the interventricular septum, it can be at any part of the left ventricle. Like for example, you see here, this is your apical hypertrophy. Right, this is the apical hypertrophy. So, in case of the apical hypertrophy, wherever might be the hypertrophy, if that particular segment increase in thickness is more than 1.5 centimeter, then we call it as the hypertrophic cardiomyopathy. Now, this particular apical hypertrophy, when you observe that under a 2D echo or by cardiac catheterization, it will appear as the ace of spades. So, you can see that here. Right, so this will appear as the ace of spades. So, you can see even in case of left ventricular catheterization as well. And so, this is one example of the hypertrophic cardiomyopathy. First one was at the interventricular septum, and later it could be at any part of the left ventricle, right? Then, now if you see some features of the hypertrophic cardiomyopathy, let me tell you, this hypertrophic cardiomyopathy, it is an inherited disorder, and it is inherited as an autosomal dominant type of inheritance. Okay, and it is due to mutation of one of large number of genes. So basically it is due to mutation of the genes. Right, basically it is due to mutation of the genes, and one of the most common gene which is being mutated is the β-myosin gene. Right, one of the most common gene that is being mutated is the β-myosin gene. And how will be the prognosis in these patients with the hypertrophic cardiomyopathy? So, prognosis in patients with hypertrophic cardiomyopathy, it is completely related to specific gene which is being mutated. Right, related to specific gene which is being mutated. Okay, and then followed by that, when will be the presentation of these patients with the hypertrophic cardiomyopathy? Patients, they usually present in the early adulthood. Right, patients, they usually present in the early adulthood. These are some of the features of the hypertrophic cardiomyopathy, but let me discuss about the mutations. See, in hypertrophic cardiomyopathy, there are greater than 100 mutations. So, greater than 100 mutations, right, greater than 100 mutations have been identified in at least 12 sarcomeric genes. Right, in at least 12 sarcomeric genes, out of which the three important genes which will account for nearly 70 to 80% are: number one, β-myosin gene mutation, right, and number two, the second gene which is being mutated responsible for hypertrophic cardiomyopathy is myosin binding protein C. Right, myosin binding protein C. And the third important protein or the third important substance which will be defective for the development of the hypertrophic cardiomyopathy is the troponin T. So, the gene which is responsible for coding of this particular troponin T mutation will also lead to the hypertrophic cardiomyopathy. So, and particularly, what is the type of inheritance I have said already? It is autosomal dominant type of inheritance. And this beta-myosin gene, the another important multiple choice question you need to know is, it is present on chromosome 14. Right, it is present on chromosome 14. And these three gene mutations, right, these three gene mutations, they account for 70 to 80% of all cases of the hypertrophic cardiomyopathy. So that is about the mutations. Then followed by that, you need to know about the athletic hypertrophy. See, elite athletes, right, these athletes, they may demonstrate considerable hypertrophy that can be confused with the hypertrophic cardiomyopathy. But this athletic hypertrophy, diastolic dysfunction is not present. In patients with hypertrophic cardiomyopathy, it is characterized by diastolic dysfunction. But the hypertrophy of the heart that you see in elite athletes, they generally don't have diastolic dysfunction. Right, there is no diastolic dysfunction which is being present in athletes causing athletic hypertrophy, right? And the next important point is the apical variety is particularly common in those of the Asian descent, right? I said you about like apical hypertrophy, that is ace of spades, that apical variety is more common in the Asian descents, okay? So this is about the various forms of the hypertrophy. And if you take some of the essential features of the hypertrophic obstructive cardiomyopathy, see, when I am using the word hypertrophic obstructive cardiomyopathy, what does that mean? Here, the hypertrophy is present exactly at the left ventricular outflow tract. Right, the hypertrophy is present exactly at the left ventricular outflow tract. And I'll just show you that. Yes, so you can observe here, this is the interventricular septum which has been the hypertrophied. And this interventricular septum which has been hypertrophied, it is not uniformly hypertrophied. So the individual will have asymmetrical hypertrophy. Right, the individual will have asymmetrical hypertrophy of the interventricular septum, right? And that is the reason why this is also called asymmetrical septal hypertrophy. And let me tell you, in case of the hypertrophic obstructive cardiomyopathy, it is only the hypertrophy of the interventricular septum. Right, it is only the hypertrophy of the interventricular septum. But what about the ventricular free wall? The ventricular free wall, it is spared. Right, the ventricular free wall, it is being spared. So you know, there is a disproportionate thickness of ventricular septum in comparison to the ventricular free wall. Right, there is disproportionate thickness of ventricular septum in comparison to the ventricular free wall. Now this interventricular septum which is asymmetrically hypertrophied, that will cause obstruction right, that will cause obstruction in the systolic ejection of the blood. Right, that will cause obstruction in the systolic ejection of the blood from aorta. Okay, so that is what will happen in patients with the hypertrophic cardiomyopathy, particularly if the hypertrophy is at the interventricular septum. There is obstruction in the systolic ejection of the blood from the aorta, and that is the reason why it is called hypertrophic obstructive cardiomyopathy. And if you take the gross specimen of the hypertrophic obstructive cardiomyopathy, what will be the shape of the left ventricle? The shape of the left ventricle, it is a banana shaped left ventricle. Right, it is a banana shaped left ventricle. And these patients with hypertrophic cardiomyopathy, because there is increase in the thickness of the muscle, cardiac muscle, right. So if you take the other essential features, right, because of increase in the thickness of the cardiac muscle, it becomes stiff. Right, the hypertrophied muscle, it becomes stiff. So once this particular hypertrophied muscle, it becomes stiff, let me tell you, these individuals will develop diastolic dysfunction. Right, these individuals will develop diastolic dysfunction. So diastolic dysfunction, it is a characteristic feature of the hypertrophic obstructive cardiomyopathy, right? Next, now after having discussed about the basic types of your hypertrophic cardiomyopathy, so the hypertrophy can be at the left ventricular outflow tract, resulting in hypertrophic obstructive cardiomyopathy. The hypertrophy can be at the apical part of the left ventricle, that is called apical hypertrophy, and the hypertrophy can be present at any segment of the left ventricle. And athletic hypertrophy, you will not have diastolic dysfunction. And the genes which are being mutated very commonly is β-myosin gene, and it is present on the chromosome 14. That β-myosin gene, it is present on the chromosome 14. Now, after having discussed about the genes and as well as the various types of the hypertrophic cardiomyopathy, let me discuss what will be the pathophysiology and as well as the clinical features in patients with the hypertrophic cardiomyopathy. So, all are true about the HOCM except asymmetrical septal thickness, left ventricular outflow tract obstruction, double apical impulse, digitalis is useful. Okay, let me tell you, okay, we will discuss this points and then come back to the same question again after the discussion. And if you take the pathophysiology or if you take the hemodynamics in patients with a hypertrophic cardiomyopathy, it is characterized by dynamic outflow tract obstruction. Now, what do you understand by this word dynamic outflow tract obstruction? See, if you take the type of hypertrophic cardiomyopathy, like where the hypertrophy is at the interventricular septum. So, in case of interventricular septum hypertrophy, the individual will end up in hypertrophic obstructive cardiomyopathy. And why? So, the hypertrophy of the septum in the left ventricular outflow tract region, it narrows the ventricular outflow tract. You see here, see this is the early part of the systole where the septum, it is hypertrophied, right? And you take the during later part of the systole. Right, during later systole. So during the later part of the systole, the hypertrophied septum, right, during the later part of the systole, the hypertrophied septum, it moves near to your anterior mitral leaflet, and at the same time, even anterior mitral leaflet, it moves towards the hypertrophied septum, and that we call it as systolic anterior motion of the anterior mitral leaflet. So basically what is happening is, during the systole, the hypertrophied septum is moving near to your anterior mitral leaflet and anterior mitral leaflet is moving near to your hypertrophied septum. So thereby what will happen to the outflow region? So in these individuals, the outflow region narrows. Right, the outflow region narrows the ventricular outflow tract. And during the mid-systole, the outflow tract is further narrowed by the systolic anterior motion of the mitral leaflet. Okay, so during mid and later part of systole, the outflow tract further narrows. Right, the outflow tract, it further narrows by systolic anterior motion of mitral valve. Right, it will further narrows by systolic anterior motion of the mitral valve, and this is what is called as the dynamic left ventricular outflow tract obstruction. Right, so this is called as dynamic left ventricular outflow tract obstruction. So what do you mean by the word dynamic? In early part of the systole, you don't have the obstruction at the outflow tract, but in the mid and as well as later part of the systole, whenever the systolic anterior motion of mitral valve develops, there is an obstruction at the outflow tract, resulting in the left ventricular outflow tract obstruction in the mid and later part of the systole, and that is what is called as the dynamic outflow tract obstruction. Now, what will be the clinical manifestation in patients with the HOCM? So, if you take the clinical manifestations, the most common presentation of the HOCM is asymptomatic, right? Most of them, they remain asymptomatic, and these cases commonly present with they commonly present with sudden cardiac death. Right, they commonly present with the sudden cardiac death. So that will be the most common presentation of these patients with the HOCM. And if at all, if they are symptomatic, in these cases, the most common symptom will be dyspnea. Right, if at all, if they are symptomatic, the most common symptom will be the dyspnea. And if you take the symptomatology in detail, right, so why does the dyspnea occurs and why other features develop, let me discuss that in detail. And symptomatic patients, they have the higher chances of mortality, and not only symptomatic, even asymptomatic individuals also, they can present with the sudden cardiac death. but the clinical manifestations or prognosis completely depends upon the gene which is being mutated. So now let me discuss why they have this particular dyspnea. So most common presenting symptom, like what we have discussed, is the dyspnea. So why do they have this dyspnea, right? This dyspnea, it is present in almost 90% of patients, and this dyspnea is largely a consequence of elevated left ventricular diastolic filling pressure. Okay, so it is a consequence of elevated left ventricular diastolic filling pressures. Right, it is a consequence of elevated left ventricular diastolic filling pressures. Okay, and once there is elevated left ventricular diastolic filling pressures, there will be increase in your left atrial pressure, increase in your pulmonary venous pressure, and increase in, so this will subsequently cause increase in the pulmonary capillary wedge pressure. Okay, so once there is pulmonary capillary wedge pressure, the individual can have the interstitial edema and alveolar edema, due to which there will be development of dyspnea. And the other important symptomatology is the pre-syncopal attack or pre-syncopal features, and that is nothing but the graying out spells. Right, so that is nothing but the graying out spells. So graying out spells that occur in erect posture, and it can be relieved by immediate lying down. So these graying out spells, they are commonly seen, or they commonly occur in erect posture. Right, they commonly occur in erect posture, and these graying out spells, they can be relieved. Right, they can be relieved by immediate lying down. Okay, so that is about the features of the, that is why you will have the pre-syncopal attack, that is the graying out spells. Then followed by that, the syncopal attack. So graying out spells will be there only in erect posture, and they get reduced whenever the individual lies down in supine position. But coming to the syncopal attack, the syncope occurs from inadequate cardiac output. Okay, so this is due to this is due to inadequate cardiac output or from cardiac arrhythmias. Right, or from the cardiac arrhythmias. Okay, and the presence of the syncope identify the patients at high risk of sudden death. So these patients with syncopal attack, they are at high risk of, right, they are at high risk of the sudden cardiac death. So that is about the syncopal attack. Why is that due to? That is due to inadequate cardiac output or from the cardiac arrhythmia. Now coming to the other important feature, that is angina. The typical symptoms of angina occurs due to impaired diastolic relaxation and markedly increased myocardial oxygen consumption. So it is the hypertrophy of the myocardium. So when there is hypertrophy of the myocardium, what will happen to your myocardial oxygen demand? There is increase in myocardial oxygen demand. But what has happened to your diastolic filling? There is impaired diastolic relaxation, so there is decreased diastolic filling. So in these individuals, there is decreased diastolic filling of left ventricle, right? There is decreased diastolic filling of the left ventricle, and there is also decrease in, subsequently there is decrease in the cardiac output, right? Subsequently there is decrease in the cardiac output. So this particular decrease in cardiac output and at the same time increase in myocardial oxygen demand, both of these will make the individual to develop angina, right? Both of these will make the individual to develop angina. So whenever there is decrease in cardiac output, actually the myocardium will suffer from the subendocardial ischemia. The heart will suffer from subendocardial ischemia. Right, and because of this subendocardial ischemia, the individual will suffer with angina. Next to this angina, the next important symptom or symptomatology is the palpitations. See, palpitations, they result from arrhythmias such as premature atrial contracture and premature ventricular beats. Okay, so these palpitations, they result from arrhythmias. Okay, and these particular arrhythmias, it could be the premature atrial contracture, right, or these particular arrhythmias could be a premature ventricular contracture, or these arrhythmias could be atrial fibrillation, or they could be atrial flutter, right, or there could be atrial flutter. So these are the reasons why the individual can develop the palpitations. Okay, and these individuals, before going on to the development of the dyspnea, I said you dyspnea is the most common symptom. Before the development of dyspnea, they can also have the features of paroxysmal nocturnal dyspnea and as well as the orthopnea. Next, the other important manifestation is these patients, they also develop the features of the congestive heart failure. And the development of congestive heart failure is relatively uncommon, but that can occur in severe HOCM patients, right? That can occur in severe HOCM patients, and this is usually diastolic failure. Right, this is usually the diastolic failure. That is what you will have in patients with the hypertrophic cardiomyopathy. And the other important manifestation is, or the clinical feature is, the dizziness. Dizziness, it is very common in HOCM patients with elevated pressure gradients across the left ventricular outflow tract, right? And this dizziness also may occur as a result of maneuvers which will decrease the preload and which will decrease the afterload. So any maneuver which will decrease the preload or which will decrease the afterload, right? Any maneuver which will decrease the preload and afterload will make the individual to develop this particular dizziness. So what are those maneuvers which will decrease the preload? Like standing from supine position can decrease the preload. And what are the maneuvers which will decrease the, it should be increase in the afterload, right? Any maneuvers which will increase the afterload will cause decrease in cardiac output, and thereby there will be decreased perfusion to the brain, resulting in dizziness. So, and what are the maneuvers which will increase the afterload? That is the hand grip, right? That can increase the peripheral resistance and thereby it increases the afterload. So this is about the dizziness. Now on examination, right? So on examination, what will be the features? So before going on to the examination, if you take the clinical manifestations, most of them, they are asymptomatic and they directly present with the sudden cardiac death. And if at all, if they are symptomatic, the most common symptom will be the dyspnea. And along with dyspnea, the other symptoms that are being present is the pre-syncopal attacks, there can be syncopal attacks, palpitations, there can be development of the congestive heart failure and then dizziness. Now coming to the on examination, what you can feel is, you can feel a double carotid upstroke, right? Now it has been discussed that during early systole, there is increased velocity of the blood flow through the left ventricular outflow tract into the aorta. So, from the left ventricle, there is increased blood flow, right? From the left ventricle, there is increased blood flow into the aorta in early part of the systole. But, so, because of increased blood flow, right? Because of increased blood flow, during early part of the systole, right, due to increased blood flow during early part of the systole, there is increase in velocity of the blood flow through the aorta, that is through your carotid. So this will give rise to first upstroke, right? This will give rise to the first upstroke. Is that clear? Then in the mid part of the systole, right, during mid or the later part of the systole, what will happen is the obstruction, it will further narrow, right? The obstruction, the left ventricular outflow tract, it further gets narrowed. And when the left ventricular outflow tract further gets narrowed, what will happen to the outflow? The outflow will be decreased. Now, in order to overcome, right, in order to overcome this obstruction, left ventricle will try to increase its contraction, and thereby there will be one more rapid jet that will go into the carotid, and that will give rise to your double carotid upstroke. Okay, so during your mid or later systole, because of the obstruction, the carotid pulse declines. Right, the carotid pulse declines, and the left ventricle tries to overcome this increased obstruction. And what is that increased obstruction? That is systolic anterior motion. So once the left ventricle tries to overcome this obstruction, the carotid pulse rises again. Okay, so left ventricle, it tries to overcome the obstruction by increasing its contractility, and thereby what will happen? The carotid pulse rises again, right? Carotid pulse rises again, and that will result in what is called double carotid upstroke. That will result in what is called double carotid upstroke. And when you palpate the pulse also, in these individuals, you will have two peaks in systole, right? And that particular two peaks in systole, that is called as pulsus bispheriens. Right, that is called pulsus bispheriens. So pulsus bispheriens is what? The presence of two peaks in systole is called the pulsus bispheriens. Okay, and not only double carotid upstroke, even if you see the apical impulse, even the apical impulse, it is a double apical impulse. And see, one particular apical impulse is due to LV apical contraction, and the later one, so this double, the second one, it results from a forceful left atrial contraction. Right, this results from the forceful left atrial contraction against, right, against a highly non-compliant left ventricle. Right, against a highly non-compliant left ventricle, and that will result in what is called the double apical impulse. Right, now coming to the auscultation in patients with the hypertrophic cardiomyopathy. So if you see the auscultation, there are some important points that you have to know. See, regarding the heart sounds, you will have first and as well as the second heart sound. But regarding this second heart sound, there can be a paradoxically, there can be a paradoxically split S2. What do you mean by the word paradoxically split S2? There will be P2 then followed by that A2, right? And why is that? That is because of increase in the time required for the flow of blood from left ventricle into the aorta. And these patients with hypertrophic cardiomyopathy, you also have the presence of S4. And why is that? That is because of forceful left atrial contraction. That is because of the forceful left atrial contraction and the characteristic murmur. So the murmur in these individuals is the presence of the ejection systolic murmur, right? And this ejection systolic murmur, it is a harsh systolic diamond shaped murmur, right? It is a harsh systolic diamond shaped murmur. Okay, that is what is your the ejection systolic murmur. Ejection systolic murmur, let me tell you, it is also present in the aortic stenosis and as well as the pulmonary stenosis. And apart from that, it is also seen in this clinical scenario, that is the hypertrophic obstructive cardiomyopathy. Now, let me discuss in detail about this ejection systolic murmur. In HOCM during systole, the blood flows through the narrowed outflow tract, right? The blood flows through narrowed outflow tract. And this produces the systolic ejection murmur. And this particular systolic ejection murmur, it is typically a harsh diamond shaped murmur. Right, it is typically a harsh diamond shaped murmur. And this murmur usually begins well after the first heart sound, since the ejection in unimpeded, see, in early part of the systole, there is no obstruction. So you don't have the murmur in early part of the systole. But in the mid part of the systole, because of SAM, that is systolic anterior motion of the mitral valve leaflet, there the obstruction begins. And that is the reason why you will have the ejection systolic murmur, which is the mid-systolic murmur. Right, which is the mid-systolic murmur. And please remember, the murmur does not radiate to carotid artery. Right, this particular murmur does not radiate to carotid artery. Now, there is also, a dynamic auscultation of this particular murmur, which I will discuss. Okay, but for now, remember, it is an ejection systolic murmur. It is a harsh diamond shaped murmur. It is heard in the mid part of the systole and does not radiate to the carotid artery. Now you see a question. All are true about the HOCM except there is asymmetrical septal thickness, left ventricular outflow tract obstruction, there is double apical impulse, digitalis is useful. Asymmetrical septal thickness, yes, it is present. Left ventricular outflow tract obstruction, yes, it is present. Double apical impulse, yes, it is present. Digitalis is useful, it is an incorrect statement, right? Digitalis is absolutely contraindicated in patients with the HOCM. Now, let me discuss about the murmur and the dynamic auscultation of this ejection systolic murmur. See, the murmur of hypertrophic obstructive cardiomyopathy is decreased in which of the following? Supine position, standing position, Valsalva and amyl nitrate inhalation. Okay, now you have to understand a very important concept here. See, this is your, right, this is your hypertrophic cardiomyopathy. Now what will happen here with the dynamic auscultation? Let me explain you. So, why there is a murmur? Because of the obstruction. See, because of the obstruction exactly at this point, you have the presence of the murmur. For suppose, right, if the obstruction is decreased, right, if the obstruction is decreased, what will happen to the intensity of the murmur? The intensity of the murmur is also decreased. For suppose, if the obstruction increases, then the intensity of the murmur also increases. And what is the next point you need to know? The next point you need to know is that when is that the obstruction will be decreased? Obstruction decreased means LV volume is increased. Right? What do you mean by the word obstruction being decreased? That means the LV volume is increased. So when LV volume is increased, the obstruction will be decreased. And when obstruction is decreased, the intensity of the murmur will be decreased. Whereas, when is that the obstruction is increased? That is when, right, that is when the LV volume is decreased. That is when the LV volume is decreased, then the obstruction increases. When obstruction increases, the intensity of the murmur increases. This is the concept. Now, you take any maneuver whichever is increasing the LV volume will decrease the murmur. Any maneuver which will decrease the LV volume will increase the murmur. That is the concept. Now, let me just see that. Now, you need to know what are the conditions which will increase the murmur. What did I tell you? What are the conditions which will increase the murmur? The conditions which will increase the murmur, increase the intensity of the murmur is that where the LV obstruction is increased or LV volume is decreased. So, any condition whichever will decrease the LV volume will increase the obstruction and will increase the intensity of the murmur. Right, will increase the intensity of the murmur. So, now what are the conditions which will decrease the LV volume? So, the conditions which will decrease the LV volume, they are equivalent to the one which will decrease the preload. Right, any conditions which will decrease the preload, what will happen to your RV volume initially? Decreases. Subsequently, what will happen to your LV volume? Decreases. When LV volume decreases, obstruction increases, murmur increases. So what are those conditions where there is decrease in the preload? Number one, Valsalva maneuver. Right. Number two, sudden standing. Right. Number three, nitroglycerin supplementation. Number four, diuretic supplementation. Next, amyl nitrate inhalation. So, all these conditions and even during, okay. So, in all these conditions, the preload, that is the venous return, decreases. Preload decreases. LV volume decreases. Obstruction increases. Murmur increases. Now, we have few more conditions which will increase the murmur. See, few more conditions which will increase the murmur is the conditions or the clinical scenarios where there is increase in the myocardial contractility. Right? Like for example, you take exercise. In second scenario, sympathomimetic amines. Right, sympathomimetic amines. Next, digitalis. So, in all these conditions, what will happen to your myocardial contractility? The contractility is increased. When contractility is increased, what will happen to your LV cavity? There will be decrease in the left ventricular cavity size. So once there is decrease in LV, left ventricular cavity size, what will happen to the intensity of the murmur? The intensity of the murmur increases. Okay. So that is about the clinical conditions where the murmur increases. And you see the conditions where there is decrease in the intensity of the murmur. Right? You see the conditions where there is decrease in the intensity of the murmur. See, conditions which increases the venous return. Whichever condition will increase the venous return will increase the LV volume. Right? Will increase the LV volume. So once there is increase in LV volume, what will happen to the obstruction? The obstruction decreases. Right? The obstruction decreases. So once the obstruction decreases, what will happen to the murmur? The murmur decreases. The intensity of the murmur decreases. Okay. Now, what are those conditions? Number one, which will increase the venous return is passive leg raising. Right. Number two, supine position. Number three, squatting position. Okay. So these are all the conditions which will increase the venous return. LV volume increases, obstruction decreases, and thereby the murmur decreases. Next, the other conditions are the conditions which will increase the systemic arterial pressure. See, any conditions which will increase the systemic arterial pressure is equal to increasing in the afterload on the left ventricle. So thereby, what will happen to your cardiac output? It will be decreased. Thereby, what will happen to your LV volume? Increases. Thereby, what will happen to the obstruction? Decreases. So thereby, what will happen to the murmur? The murmur also decreases. Right? So what are the conditions where there is increase in the afterload? That is sustained hand grip, right? That is sustained hand grip. Then elevation of arterial pressure by phenylephrine. Right? Elevation of arterial pressure by phenylephrine. Okay. Next, the other conditions is the conditions which will decrease the ventricular contraction will also increase the size of the ventricular cavity. Now, you take any clinical scenario or any drug which will decrease the LV contractility, LV volume increases, obstruction decreases, murmur decreases. So now what are those drugs which will decrease the ventricular contraction? That includes the beta blockers. Right? And the next important group of drugs are the calcium channel blockers. So these beta blockers and calcium channel blockers, they will decrease the LV contractility. So once the LV contractility is decreased, the obstruction decreases and the intensity of the murmur also decreases. So going back to the question now, the murmur of hypertrophic cardiomyopathy is decreasing in which of the following condition? So you take in case of supine position. What will happen in supine position? The venous return increases. Right? When venous return increases, LV volume increases. When LV volume increases, right, when LV volume increases, the intensity of the murmur decreases. Okay. So this is about the murmur of hypertrophic cardiomyopathy is decreased in which of the following condition? That is in supine position. In standing position, the LV volume decreases. Valsalva maneuver, there will be decrease in venous return. Amyl nitrate inhalation, there will be decrease in venous return. So in all these conditions, the intensity of the murmur increases. Okay. So the murmur of hypertrophic cardiomyopathy is decreased in which of the following condition? That is in supine position. Now coming to the investigations. So definitely the first line investigation will be your echocardiography. So echocardiography will be able to tell you the diagnosis of the hypertrophic cardiomyopathy. Now, but apart from that, the ECG. So ECG, what you will observe, the presence of or development of the left ventricular hypertrophy, right? And you will notice the high voltages across the precordium. Right, you will notice the high voltages across the precordium, and there will be also prominent, right, there will be also prominent Q wave, and there will be also, right, there will be also tall R wave in the precordial leads. Let me show you that ECG. So this will be the ECG in which you are able to observe the prominent Q wave, and this particular prominent Q wave, we call this as a dagger shaped Q waves. Right, this we call it as dagger shaped Q waves. And even if you observe the T wave, there is the T wave inversion. And what will happen to the amplitude of the R wave? The R wave amplitude is very high. So that is about the ECG in patients with the hypertrophic cardiomyopathy. Then coming to the 2D. See, in the 2D echo, what all you will observe is, definitely this is the best investigation, and this will demonstrate systolic anterior motion. Right, this will demonstrate the systolic anterior motion of the mitral valve. Right, and this will also demonstrate the hypertrophied septum. Right, so that will be the 2D. Next, the other investigations are the myocardial perfusion. The myocardial perfusion imaging may suggest the septal ischemia in the presence of normal coronary arteries. So myocardial perfusion may show you the presence of septal ischemia. Why is that? That is because of increase in the demand, decrease in the flow. But how will be the coronaries? Normal coronary arteries. Right, normal coronary arteries. And what about cardiac MRI? Cardiac MRI confirms the hypertrophy and contrast enhancement. Right, confirms the hypertrophy and confirms the hypertrophy and the contrast enhancement. Okay, so that will be the cardiac MRI. And the cardiac catheterization confirms the diagnosis and defines the presence or absence of the coronary artery disease. So this will confirm the diagnosis. And the cardiac catheterization will also tell you if there is presence or absence of, presence or absence of the coronary artery disease. So that is about the cardiac catheterization. And the exercise testing. See, what is the importance of the exercise testing or exercise studies is that exercise studies are recommended to assess for ventricular arrhythmias. Right, that is to assess for that is to assess for the ventricular arrhythmias and to document the blood pressure response. right, to document the blood pressure response. So patients in whom the systolic blood pressure does not increase more than 20 millimeters of mercury during treadmill testing, they are also at risk. So during the treadmill testing, we need to see how much is increase in the blood pressure, right? How much is the increase in blood pressure? So if the blood pressure does not increase, right, if the blood pressure does not increase more than 20 millimeters of mercury, these individuals, they are at risk of sudden cardiac death, right? They are also at risk as those with double and compound genetic mutations. So basically, please remember this. Exercise studies are mainly to rule out is there any presence of the development of ventricular arrhythmias and to document the blood pressure response. And if the blood pressure is not increasing more than 20 millimeters of mercury during treadmill testing, they are also at risk of the sudden cardiac death. And in these individuals with hypertrophic cardiomyopathy, loop monitoring is also very important. See, this is recommended for determination of the ventricular ectopics. Right, this is for determination of for the determination of the ventricular ectopics. See, what we do in loop monitoring is an implantable loop recorder is implanted over the left side of the chest. So, implantable loop recorder. So, this implantable loop recorder, it is a type of heart monitoring device that records your heart rhythm continuously for up to 3 years, right? So this will monitor heart rhythm continuously for up to 3 years, and it records the electrical signals of your heart, right? It records the electrical signals of your heart and allows remote monitoring by way of a small device inserted just beneath the skin of the chest. Okay, so that is the advantage of the loop monitoring, because these patients with hypertrophic cardiomyopathy, they are more prone for arrhythmias and sudden cardiac death. So in order to monitor the rhythm, this implantable loop recorder is placed beneath the skin of the left side of the chest. Now, after having discussed about the investigations in hypertrophic cardiomyopathy, let me discuss the treatment part. See, a 9-month-old child of a diabetic mother presents with tachycardia and hepatomegaly. Echocardiography of the heart showed normal cardiac morphology with asymmetrical septal hypertrophy. Which of the following you will give to treat this child? Digoxin, furosemide, propranolol, isopten. Isopten is nothing but your nitrate. So let me tell you, the drug of choice, right? The drug of choice for patients with hypertrophic cardiomyopathy will be the beta blocker, that is propranolol. Now let me discuss the treatment in detail. So if you take the medical management, right, if you see the drugs, drug of choice will be the beta blockers, right? Drug of choice will be beta blockers. So what it will do, the mechanism, it will reduce the heart rate. Because it reduces the heart rate, it reduces the oxygen consumption. Right, it reduces the oxygen consumption. Okay, and in those individuals where you cannot give the beta blockers, you need to give calcium channel blockers, and these calcium channel blockers will be verapamil. Right, these calcium channel blockers will be verapamil. So these beta blockers, when they reduce the heart rate, what is the advantage? They will also increase the duration of the diastolic filling time. right? They will also increase the duration of the diastolic filling of the heart. And as it increases the duration of the diastolic filling, that will also try to increase the cardiac output as well. These drugs, they will also try to increase the cardiac output as well. And let me tell you, there are certain group of drugs that are absolutely contraindicated in HOCM. Now, you need to know what are the drugs which are contraindicated in HOCM. See, that particular group of drugs that increases the myocardial contractility. So, drugs which will increase the myocardial contractility, what it will do to the obstruction? Obstruction is increased, output decreases. So, what are those drugs? Like digoxin should not be given. Next, sympathomimetic amines. Right, they are contraindicated. Next, the other group of drugs that are being contraindicated is the drugs which decreases ventricular volume. See, the drugs which will decrease the preload will decrease the ventricular volume. Now, once there is decrease in ventricular volume, what will happen to the obstruction? Obstruction increases. Example, the nitrates. Right, nitrates, they will increase the obstruction. Then diuretics, they will also increase the obstruction. So once the obstruction increases, the cardiac output decreases. So these are the drugs contraindicated. The drugs that will increase the myocardial contractility, that is digitalis and sympathomimetic amines, and the drugs which will decrease the ventricular volume or preload, that is nitrates and as well as diuretics. So to summarize the management of the HOCM, first and foremost, avoidance of the strenuous physical activity. And beta blockers, they will reduce the heart rate and they will reduce the blood pressure, they will reduce the stiffness of the left ventricle, and they will also reduce the fatal arrhythmias. And in those individuals where the beta blockers cannot be given, the alternative drugs are the verapamil and as well as the diltiazem. And how do you manage the patients with drug refractory symptoms, right? Not responding to drugs. In those individuals, what is that you will do? So in these patients, right, in these patients, the management include surgical myomectomy, right, surgical myomectomy, or the other alternative procedure is alcohol septal ablation or septal ethanol ablation. Right, septal ethanol ablation. And these patients, they also, in individuals who have the risk of arrhythmias, they have to be placed on, right, they have to be placed on implantable cardioverter-defibrillator. Okay, so this will be the treatment for patients with drug refractory symptoms. Now, to summarize the treatment, so in patients with hypertrophic cardiomyopathy, you need to look for if the obstructive physiology is present or not. If the obstructive physiology is present, then yes, that means if obstructive physiology is present, then you need to avoid the vasodilators and diuretics. Please don't give them, because that will further reduce the venous return and that will reduce the LV volume, that will increase the obstruction. Okay, and next thing, you have to check whether the individual is having heart failure or angina. If the heart failure or angina is present, then you give either beta blockers. If contraindicated, then give the calcium channel blockers. If heart failure or angina is not present, then annual visit has to be advised. Right? The annual visit has to be advised. Now, in spite of giving this beta blockers and verapamil, if there are persistent symptoms, then invasive therapy has to be done. Then he is a surgical candidate. Right? If he is suitable for surgery, then surgical myomectomy or the alcohol ablation should be done. And if he is not suitable for surgery, then dual chamber pacing has to be done. So this is the story if the individual has an obstructive physiology. If the individual has no obstructive physiology, right, the heart failure or angina is present or absent, you have to check. If not present, just ask them for annual visit. If present, then you need to check for the systolic function. If the systolic function, if it is less than 50%, then standard heart failure therapy should be given. And if systolic function is more than or equal to 50%, beta blockers or verapamil, diuretics or ACE inhibitors or ARBs should be given. So this is about the summary of treatment of the hypertrophic cardiomyopathy. Now subsequently, let me discuss the prognosis and some multiple choice questions on the topic of the hypertrophic cardiomyopathy. Let me tell you how will be the prognosis in these individuals. See, these individuals, they have to be advised to avoid the exertional activity, right? So whenever the individual does a very severe exercise or any strenuous activity, the individual can have a sudden death, right? The individual can have a sudden death, and that may be the initial event. Okay, so sudden death, especially during exercise, may be the initial event. And what are those group of individuals who are at high risk of this particular sudden death? See, this particular sudden death, it is very common in those individuals with a personal history of serious ventricular arrhythmias or an individual who has survived sudden death episode. So, those individuals with personal history of serious ventricular arrhythmias right, or those individuals who have survived a sudden cardiac death. This will be one group of individuals who can have a sudden death. Next, second group of individual who can have the sudden death during exercise is in those individuals who have the family history of sudden death. Right, in those individuals who have a family history of sudden death. Right, and the third important group of individuals who are at risk of sudden death will be an individuals with unexplained syncopal attack. So these are the group of individuals. Right, these are the group of individuals who are at risk of the sudden death during exercise. Now, apart from this, the other group of individuals who are at high risk, those individuals with documented non-sustained ventricular tachycardia. What do you mean by the word non-sustained ventricular tachycardia? It is defined as 3 or more beats of ventricular tachycardia at 120 beats per minute or more on ambulatory ECG. So basically, documented non-sustained ventricular tachycardia patients, they are also at risk of the sudden cardiac death. And in those individuals where the maximum left ventricular wall thickness of 30 mm or more. So these are also the group of individuals at risk of the sudden cardiac death. So this is how the prognosis in patients with the hypertrophic cardiomyopathy will be. Now, let me discuss some MCQs with clinical scenarios and the single liner questions. So we have a 56-year-old patient with stage D ischemic cardiomyopathy comes to you for a second opinion. He is already receiving furosemide, an AC inhibitor, a beta blocker, spironolactone. He has been told by a specialist that he needs a device to avoid dying from irregular heart rhythm. What non-pharmacological treatment are available for prevention of sudden cardiac death in patients with the ischemic cardiomyopathy? Ventricular assist device, implantable cardioverter-defibrillator, biventricular pacemaker, intra-aortic balloon pump. See, these patients with ischemic cardiomyopathy, they can have the malignant ventricular arrhythmias, right? So, they are predisposed for the development of the ventricular arrhythmias. And these particular ventricular arrhythmias, right, these particular ventricular arrhythmias, that includes the VT or the VF. So, in order to terminate this particular ventricular tachycardia or ventricular fibrillation, the patient has to be placed on the implantable cardioverter-defibrillator. Okay, so when you put the patient on implantable cardioverter-defibrillator, that can terminate, right, that can terminate the ventricular tachycardia or the ventricular fibrillations. And you take the other options like biventricular pacing. Biventricular pacing improves prognosis in patients with severe congestive heart failure, but they have no role in the management of the ischemic heart disease causing the fatal arrhythmias. So, this biventricular arrhythmias has a role in the treatment in patients with the severe congestive heart failure. But this biventricular pacemaker, it has no role in the management of lethal arrhythmias. And you take this ventricular assist device and as well as the intra-aortic balloon pump. Both intra-aortic balloon pump and as well as the ventricular assist device, both of them, they are mechanical devices utilized as a bridge to cardiac transplantation for patients with very severe congestive heart failure. So particularly if you take this ventricular assist device, so even this and as well as IABP, they both of them, they act as a bridge. Right, both of them, they act as a bridge to cardiac transplantation for patients with very severe congestive heart failure. Okay, so the answer to this particular question is the implantable cardioverter-defibrillator. Now, if you see the next question, all are true regarding the specimen shown except asymmetrical septal hypertrophy, left ventricular outflow tract obstruction, diamond-shaped cavity of the left ventricle, diastolic dysfunction. So the question is like, which is the incorrect statement? And the specimen, whatever has been shown within the image, it is suggestive of, right, it is suggestive of the hypertrophic cardiomyopathy. So in patients with hypertrophic cardiomyopathy, they definitely will have asymmetrical septal hypertrophy, they definitely will have left ventricular outflow tract obstruction, they definitely will have the diastolic dysfunction. But if you take the shape of the left ventricle, it will be a banana shaped left ventricle. Right, the lumen, it will be of banana shape. Lumen of the left ventricle will be of banana shaped. They will not be diamond shaped cavity of the left ventricle. Okay, so the question asked is except diamond shaped cavity of the left ventricle will not be there. Banana shaped left ventricle will be there. Okay, now after having discussed that, you see the next question. Which of the following is not a single gene disorder? Mitral valve prolapse, hypertrophic obstructive cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia. So the one which is not a single gene disorder, it is the hypertrophic obstructive cardiomyopathy. Let me tell you, in patients with hypertrophic obstructive cardiomyopathy, there are more than 100 mutations. Right, there are more than 100 mutations that have been identified in at least 12 sarcomeric genes. Right, that have been identified in at least 12 sarcomeric genes. Okay, and out of which the very important gene which is being mutated is the gene which will code for the beta-myosin heavy chain. Right, beta-myosin heavy chain. Okay, and the other genes which are being mutated are the genes which will code for proteins, that is myosin binding protein C and as well as the troponin T. So these three genes, that is beta-myosin heavy chain gene and myosin binding protein C gene and troponin T gene, they account for almost 70 to 80% of cases of the hypertrophic cardiomyopathy. Okay, right. Then, and followed by that, let me tell you that these patients with hypertrophic obstructive cardiomyopathy, the type of inheritance is autosomal dominant type of inheritance. Okay, then if you see the discussion about arrhythmogenic right ventricular cardiomyopathy, arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy is that where the ventricular wall, which one? The right ventricular wall, it is severely thinned out. Right, it is severely thinned out. Why? Because there will be myocyte replacement by massive fatty infiltration. So myocytes, they are replaced, right? Myocytes, they are replaced by massive fatty infiltration. Right, by massive fatty infiltration. That is what is your arrhythmogenic right ventricular dysplasia. So there will be fatty infiltration and as well as there will be lesser amounts of the fibrosis as well. And most of these cases of arrhythmogenic right ventricular dysplasia, they are sporadic in nature. Right, most cases are sporadic in nature. But familial forms do occur with gene defects localized on chromosome 14. Right, with the gene defects localized on chromosome 14. Right, and the type of inheritance of this arrhythmogenic right ventricular dysplasia, this is also an autosomal dominant type of inheritance. Okay, and the gene which is being mutated, that is involved in desmosomal junctional proteins. Right, the gene whatever is being mutated, right, the gene whatever is being mutated, it is involved in, right, it is involved in desmosomal junctional proteins. Right, it is involved in desmosomal junctional proteins. So that is about your arrhythmogenic right ventricular dysplasia, but it is a single gene mutation. It is not like multiple gene mutations like what you see in case of hypertrophic cardiomyopathy. Okay, next. You see another question. A 25-year-old footballer is elbowed in the chest by the rival defender during the ball possession. Following the chest trauma, the player collapses and dies. The most probable cause of the death is hypertrophic obstructive cardiomyopathy, commotio cordis, hemothorax, aortic transection. So the answer to this particular question is the commotio cordis. It is not hypertrophic obstructive cardiomyopathy. See, what is this commotio cordis? It is the disorder or it is a clinical condition where the individual after a blunt non-penetrating trauma over the chest will trigger the ventricular fibrillations. Okay, so what is commotio cordis? It is the disorder where an individual after a blunt non-penetrating trauma over the chest. Right, after a blunt non-penetrating trauma over the chest, this will trigger the ventricular fibrillation even in the absence of the overt sign of the injury. And this syndrome is referred to as the commotio cordis. And this most often occurs in adolescents during the sporting events. right? Most often it occurs in the adolescents during the sporting events, and probably results from an impact to the chest wall overlying the heart. Okay, and the survival, it completely depends upon the prompt defibrillation. So what is the treatment that you have to give in this individual is prompt defibrillation. Okay, so the survival of the individual completely depends upon the prompt defibrillation. Okay, so that is about your commotio cordis, right? Next. All are true about hypertrophic cardiomyopathy except systolic dysfunction, concentric hypertrophy, diastolic dysfunction, double apical impulse. So, in the beginning of the session itself, I have taught you that in patients with hypertrophic cardiomyopathy, what they will have is diastolic dysfunction. But what is the question asked? The question asked is except. So, the one which will not be seen in patients with hypertrophic cardiomyopathy is systolic dysfunction will not be there, but there will be concentric hypertrophy. Why there will be concentric hypertrophy in patients with hypertrophic cardiomyopathy is due to left ventricular outflow tract obstruction. Right, that is due to left ventricular outflow tract obstruction. Right, so due to left ventricular outflow tract obstruction, that will make the individual to develop the concentric hypertrophy. Right, and because of this concentric hypertrophy, the individual will develop the diastolic dysfunction, and double apical impulse is due to forceful left atrial contraction as well. So apart from the apical impulse of the left ventricle, there will be forceful left atrial contraction, and that will give rise to a double apical impulse, right? So that is about the hypertrophic cardiomyopathy. Next question is, in case of sudden death in a young football player, the first clinical suspicion would rest on which of the following differentials? Arrhythmogenic right ventricular dysplasia, Takotsubo cardiomyopathy, atrial septal defect, Eisenmenger complex. See, in case of sudden death in a young football player, one of the differential what you need to think of is the hypertrophic obstructive cardiomyopathy, right? So the most important cause of sudden death in professional footballer is in the setting of β-myosin testing being available is not HOCM. So for example, you have checked for a β-myosin chain and the β-myosin chain is normal, right? But still the individual had a sudden cardiac death. So what would be the next important differential diagnosis? That would be arrhythmogenic right ventricular dysplasia. I have taught you just now. The gene which is being mutated is desmin gene, and this particular desmin gene is present on the chromosome 14, and this desmin gene is responsible for the defect, right? And what is the defect in the muscle? The right ventricle leading to fibrofatty replacement of the muscle, right? The muscle, it is replaced by muscle is replaced by muscle is replaced by the fibrofatty tissue. Okay, and these patients in setting of adrenergic stimulation can develop ventricular tachycardia. Okay, so this particular fibrofatty tissue will generate the abnormal impulses and can make the individual to develop the ventricular tachycardia, right? Can make the individual to develop ventricular tachycardia, where in the adrenergic stimulation, see, a young football player, right, during the football he will be in a state of stress, anxiety and emotions. So there will be adrenergic stimulation, and that will make the individual to develop a ventricular tachycardia, or the individual can develop the Torsades de Pointes, right? Or the individual can develop Torsades de Pointes. So both of these scenarios will make the individual to land up in death, right? Both of these scenarios will make the individual to land up on death on the football field. Okay, next you take this Takotsubo cardiomyopathy. Takotsubo cardiomyopathy presents in the setting of the catecholamine surge, like an emotional breakup or getting stuck in an elevator during an earthquake. So that will be your Takotsubo cardiomyopathy. Takotsubo cardiomyopathy, it is not the one which you see in a young football player. But in arrhythmogenic right ventricular dysplasia, a young football player with arrhythmogenic right ventricular dysplasia, they can have sudden cardiac death. And in arrhythmogenic ventricular dysplasia, you have a characteristic wave in the ECG, right? You have a characteristic wave in the ECG. And this particular characteristic wave in the ECG is the epsilon wave. And this particular epsilon wave is characteristically seen in lead V1 in arrhythmogenic right ventricular dysplasia. Okay, right. After having discussed about this, you see the next question. A 35-year-old farmer consulted a local medical practitioner for recurrent attacks of the chest pain. His elder brother had similar complaints and had died suddenly at the age of 40 years. The farmer was advised to take nitroglycerin sublingually at the time of pain. However, the patient finds that the intensity of the pain increased by nitroglycerin. Most probably this particular patient is suffering from subacute bacterial endocarditis involving the aortic valve, hypertrophic obstructive cardiomyopathy, degenerative mitral regurgitation, chronic type A dissection of the aorta. So this particular patient is suffering with what is called the hypertrophic obstructive cardiomyopathy. So what are the points? Number one, his elder brother had complaints and had died suddenly at the age of 40. That means there is a family history. And second important point is that by taking nitroglycerin sublingually, the chest pain is increasing. In patients with hypertrophic obstructive cardiomyopathy, whenever you give the sublingual nitrates, right, whenever you give the sublingual nitrates, this will reduce the venous return. Right, this will reduce the venous return. So, as the venous return reduces, what will happen to the cardiac output? Decreases. And thereby what will happen to the myocardial perfusion? It reduces. And further, the individual will have a very severe chest pain. Okay. So, that is about your hypertrophic obstructive cardiomyopathy. Right. Next. So, in patients with hypertrophic obstructive cardiomyopathy, you should not give sublingual nitrate. It will further accentuate the chest pain of the individual. Right? Next question. A 25-year-old basketball player suddenly collapsed while undergoing an athletic event and died. At autopsy, the septum was hypertrophied. What is the most probable diagnosis? Hypertrophic obstructive cardiomyopathy, right ventricular conduction abnormality, epilepsy, snake bite. So, here it is a clear-cut case of the hypertrophic obstructive cardiomyopathy. Why? Because even the biopsy is showing that the septum is hypertrophied. So, it's a case of hypertrophic obstructive cardiomyopathy. So, summarizing the topic of hypertrophic obstructive cardiomyopathy, in these individuals, it is an autosomal dominant type of inheritance. More than one gene is being mutated, right? And these patients, they can have a sudden cardiac death. So, this completes the discussion of the hypertrophic cardiomyopathy. Thank you very much.